2019 analysis done by the Association of American Medical Colleges, it was projected that there would be a shortfall of physicians of up to 124,000 physicians by the end of the next decade. This projection was made pre-pandemic, and then the pandemic hit. And along with the pandemic came unprecedented stresses on the healthcare workforce, including on the physician workforce. We asked the question then, what did this do to the work intentions of the U.S. physician workforce? And so we surveyed close to 2,000 physicians about their intent to reduce clinical effort, their intent to leave their current practice, and their intent to leave medicine altogether. I'm Dr. Christine Sinski, Vice President of Professional Satisfaction at the American Medical Association. Today, we're discussing a paper that was led by my colleague, Dr. Tate Schoenefeld. The paper is Career Plans of U.S. Physicians After the First 2 Years of the COVID-19 Pandemic. In this study, we found that 2 out of every 5 physicians intends to reduce their clinical effort in the next 12 months. This is more than double the rate that we had found in a similar survey in 2014. When asked for the major reasons for the intent to reduce clinical effort, physicians identified 3 reasons. 1, the work was no longer fulfilling. Or 2, the current workload required more time than allotted in their clinical FTE. And 3, not feeling valued by their organizations. So that was intent to reduce clinical effort. We also asked about intent to leave their current practice. And 1 out of 5 physicians indicated that they were likely to leave their current practice within the next 2 years. Now that number is pretty similar to what we found in 2014. What was different was the number of physicians who planned to leave medicine altogether. In 2011, that number was around 1%. In 2014, when we asked a similar question, that number had risen to 2.2%. When we asked this question at the end of 2021, what we found was that 3.5% of physicians intended to leave medicine altogether. So that's more than 3-fold higher than the intent to leave medicine altogether that we found in 2011. Now, we know from other studies that approximately 1/3 of physicians who express an intent to leave will actually leave. So what happens if 1/3 of that 3.5% of all U.S. physicians leaves medicine altogether? Well, that would mean that we would lose over 20,000 physicians from the U.S. physician workforce. And we would lose those physicians right at the time that there's a projected shortfall of physicians of up to 124,000 physicians. It's very costly to an organization when physicians leave their practice. It's been estimated to cost between $800,000 and $1.3 million per physician who leaves. In addition, there are excess healthcare expenditures incurred by payers and patients when physicians leave, and that bond between the physician and their patient is broken. We know from a study that we published recently that when patients lose their primary care physician, there are excess healthcare expenditures. Receiving care at a more expensive site of service or receiving additional tests and treatments that might otherwise not have been necessary. And this amounts to then about $80,000 in excess healthcare expenditures per departing primary care physician. So what can be done? At the individual level, physicians can reduce their FTE clinical, and that has been shown to result in subsequent reduced levels of burnout. But it is not a scalable strategy. If the majority of physicians in the U.S. were to cut back further on their percent clinical FTE, then the effective physician workforce would further shrink and patients would have even less access to physician care. But there are many things that can be done at the external environment level to improve the care environment in which patients receive care, in which physicians deliver care. And so there are opportunities for policymakers, for regulators, administrators, technology vendors to share in accountability for improving the care environment. Efforts can be made to improve practice efficiency by improving teamwork, team stability, team structure, team skill level. And these efforts can then reduce a lot of the waste that's happening currently from an operational standpoint within the delivery of healthcare. In addition, we can reduce some of the system sludge that's in healthcare by de-implementing policies that may have made sense at one point, but may no longer be meeting their intentions. The National Academy of Medicine and the Surgeon General have each recently released reports with recommendations for what can be done to address clinician well-being. In addition, at the American Medical Association, we have created a wealth of resources for improving organizational culture, for improving practice efficiency, all in an effort to improve physician and other healthcare professional well-being. I encourage you to read the paper, Career Plans of U.S. Physicians After the First 2 Years of the COVID-19 Pandemic, that will be published in the November issue of Mayo Clinic Proceedings.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.